Recognize Mr. Crenshaw for 5 minutes of questions.
Thank you to the chair and ranking member. Thanks to the witnesses for being here. Anytime we create a government program, we have to ensure they're living up to the intent of the law, and the 340B program was created to help underserved communities. And now there's a debate whether it was created to help the provider or whether it was created to help the patient. In Texas, we've focused on the safety net hospital system, and I'm happy that many of our hospitals are going above and beyond providing charity care. With that in mind, we also need to ensure the principles are applied to the 340B program. So I just want to get some facts straight and some understanding of maybe the divisions in how we see this program. It's ultimately designed to help patients. We agree on that, but we see conversations about ensuring the benefits of the 340B program, the discounts are reaching the patient. To that end, there's also been some controversy about whether we should have a patient ID so that we can match the savings with the patient. To Mr. Perry and Dr. DeGiorgio, maybe you could each comment from your perspectives on why a patient ID or a new definition of patient is either helpful or not helpful for programs' integrity and for patients. We'll start with Mr. Perry.
I can't really speak to patient ID, but I can tell you how we do it. We are very, very focused on compliance. We have to make sure that we are only being able to capture 340B savings on prescriptions that are for patients that are our patients. And the stakes are simply too great for us if we don't. If we start capturing a lot of patients that don't meet that qualification that has been laid out by HRSA and in the statute, we are at risk for paying back a tremendous amount of money, and that would be absolutely devastating to us. We have a lot at stake to do it right, and all the people I know that are in this program feel the same way.
I think the question about a patient ID is more of a concept of being able to capture each individual patient that is then in a transparent way that could be audited, or is, what? And my question would be, what kind of administrative burden does that entail, or do you already do it anyway?
Well, we track every one of our patients anyway, but I don't know how an ID system. I don't know how that would work.
Yeah, Dr. Giorgio.
Yeah, I think it's important to know, where these patients get their care. We see it all the time where a patient may be seen once or twice at one institution, but they get the majority of care at our institution, and they're not even offered a follow-up at that other institution. And I think it's some sort of way of tracking to see if that institution is then trying to get 340B benefits for that patient, even though they're getting a majority of care with us, I think would certainly be helpful.
And how important are metrics like disproportionate share hospital percentage, the amount of payments given to hospitals for uncompensated care? How does that factor in?
So the DISH metric I like because it's really tough to game that metric, right? So it's based on total inpatient days. I think that's a metric that's very difficult to game. Metrics like uncompensated care and charity care, there's a little bit of room for creative accounting there, especially when you consider uncompensated care. That includes bad debt. So just because an insurance company doesn't approve the bill doesn't mean that the hospitals is providing charity care for that. That just means that they didn't get paid. And then because hospital prices, there's not a lot of transparency in what prices mean. Just because a hospital says that an MRI costs $18,000 doesn't mean the MRI is actually $18,000 when you can get it down the street at an imaging center for $600. So there's a lot of creative accounting that can go into those sort of metrics.
Yeah, part of that creative accounting is the duplicate discounts. I think everybody agrees would be a problem, and some states don't have a means to report whether those duplicate discounts are happening. What are some solutions to that? Would greater transparency around duplicate discounts be beneficial? We'll open to that to the same, if anyone.
Yeah, certainly. I mean, right now there's states that don't even have any reporting mechanism to see if a drug was a 340B and an MDRP purchase.
And many of the proposals that have been discussed include an independent clearinghouse for all claims that would help identify those duplicate discounts.
Okay. Any other things to add?
Again, we work very hard to make sure that we don't have duplicate discounts because, again, we don't want to have to repay anything. And so that's something that we use our computer systems to make sure we track it well.
Okay.
I think it's telling that two very large states, New York and California, made it a point to carve out 340B out of their Medicaid managed care systems because they're so concerned about that discount and the money that they were losing by not capitalizing on the MDRP and instead foregoing it in favor of the CEs.
Okay. The public has no idea what you just said, but
That goes for a lot of things.
it's complicated, and I appreciate you being here to talk about this complex and important subject. Thank you.